lecturer of the day. This is Dr. Kevin Tucker. Dr. Tucker is an assistant professor of medicine at Harvard Medical School and a nephrologist here at the Brigham Women's Hospital. He's the former director of the Nephrology Fellowship Program at Mass General and the Brigham, and was my program director when I was a fellow. He's the vice president of education at Mass General Brigham, and a wonderful teacher who's received recognition for his teaching both at the University of Alabama and the Brigham Women's Hospital. He's an expert in dialysis and peritoneal dialysis, and I'm really happy to have him here today to help talk to us. And his first lecture is going to be a patient perspective, including patients who generously agreed to give their time today to attend our course and let us know a little bit about what it's like being a patient on dialysis. Thank you very much, Dr. Tucker.
Thank you, Dr. McMahon. So good morning. Welcome, everyone. Thank you for joining us again for this course. We're delighted to kick off today's session, conference with a patient perspective on dialysis dosing. So let me tell you a little bit about the genesis of this presentation. For several years, I gave a lecture on dialysis dosing. But what we realized is that the patient perspective on the dose of dialysis is quite different from our perspective as nephrologists. And I think we can get a lot of really insightful information by hearing the patient perspective about the dialysis dose. And so that's how we're going to approach this topic, is by hearing the patient voice. And so we have a panel of patients and a dialysis nurse here today. And I'm going to ask them to introduce themselves alphabetically. So I'll start with Miss Vanessa Evans and ask her to introduce herself.
Okay, thank you so much, Dr. Tucker. Wonderful to be here again today. We've done this a couple of times in one of my favorite meetings with Daphne and Paul. So my name is Vanessa Evans. I am a dialysis patient. I have been a dialysis patient, believe it or not, almost 30 years. I'm what they call highly sensitized, meaning it's very hard for me to get a kidney transplant, although I hope maybe in the future that will change. That being said, I have done in-center dialysis for 8 years, and I'm currently home doing home hemodialysis with the next stage system, and I've been doing that for 21 years. So a lot to talk about.
Wow, that's pretty impressive.
Yes. I'm in it to win it, as we say. Yes.
Right. Mr. Moore, would you introduce yourself, please?
Yes, hi. My name's Paul Moore. I've been a dialysis nurse for about 34 years, the majority of that in the inpatient setting.
Great. Thank you. And Ms. Rhodes.
Thank you for having me. My name is Daphne Rhodes. I am a 22-year dialysis patient. I did 11 years during the start of my dialysis journey on PD, and the latter 11 years on hemo in-center.
Great, thank you. So I want to start by talking about the concept of dialysis adequacy. It's a term that we use a lot in the dialysis world, and we sometimes use that term with patients. We'll say your dialysis adequacy is good or it's not so good. So what I'd like to know is, when we use that term, what does it mean to you? So let me start with you, Ms. Evans. What does that term dialysis adequacy mean to you?
So I would say that dialysis adequacy means how well, at least for me, how well am I, clearing my blood? What do my labs look like? How do I feel? But I don't always think adequacy goes with how you feel, right? Sometimes I think that your labs might be really good, but you're not feeling great, or vice versa. So there is something to be said there, just from a patient side. But I think of adequacy in general in terms of my clearance, right? What does that look like?
Great. What about you, Ms. Rose? What does it mean to you?
The time, my 4-hour run from start to finish, if I'm getting good enough dialysis within those 4 hours, if they taken enough off, too much off, and the timing. And if I'm getting clear, if my blood is getting clean within that time, and or we have to change and modify some things.
So I want to follow up on those concepts a little bit. So, Ms. Evans, how did you come to your understanding of dialysis adequacy? Is this something that you've been at this a long time, 30 years? Is this something that you sort of come to yourself? Excuse me, or is it something that your clinicians talked to you about and sort of gave you a definition of adequacy of dialysis?
So we do get monthly labs, right? That we can see our labs and see, where we fall in range. So I'll be honest with you. I mean, I've been at this a long time, so I obviously know. And so part of it is looking at my labs and seeing, and so then I have my monthly talk with my physician and my healthcare team, and we, change medications accordingly. So I think that's one thing. There is also, again, I do dialysis at home and I do it more frequently. So I don't want to say I don't really watch my fluid, but I don't really, because I'm doing dialysis 5 or 6 days a week. But what I do notice for me sometimes also is just how am I feeling in general. Dialysis does take a lot out of you. And so, sometimes I feel like, oh, I need to go to bed a little earlier, and think about like how I'm programming my day. So that actually comes into, for me, my adequacy, because my adequacy for me is not only my labs, of course, that's one part of it, but it's also my overall well-being. How am I feeling? How do I go about the day? And so sometimes I make my own personal adjustments, not with medication or anything like that, but just knowing like I need to get on the machine a little earlier because I need to go to bed a little earlier. So that falls into adequacy for me as well, because it really does make a difference on how I feel day to day. And sometimes I've noticed that can be even, I don't want to say more important than dialysis, but it's like a balance, particularly as I get older and work and things like that, just trying to balance the day.
So, Ms. Evans, you just said something that I really want to highlight, because I think what I hope our learners will take out of this session, probably more than anything else, is the concept that dialysis adequacy is much more than urea clearance or KT/V.
Yeah.
So the KT/V can be meeting our target, but if the patient is not thriving, is not feeling well, then the dialysis may not be adequate. So I don't care what the KT/V is. If the patient is not thriving, their sense of well-being is not good, then perhaps the dialysis is not adequate. And I think that is the mistake, the trap that a lot of us fall into, is that we say, oh, well, the KT/V is 1.5. Everything is good. Well, maybe, but maybe not, because so I think that's where we're moving as a discipline in nephrology, is really trying to expand our purview, our view of what dialysis adequacy is, to make it much broader and really take the patient-centered perspective as to how they're feeling into account in terms of how we're thinking about the adequacy of dialysis. So thank you for hammering home that point, which I really think is important. Ms. Rhodes, let me turn to you. Now, in full disclosure, you're my patient.
Yes, I am.
We've been together for a long time, so don't feel like you have to sugarcoat anything that to make it sound like I'm a good doctor.
You're a great doctor.
I want you to be honest with us. How did you come to your concept of what dialysis adequacy is? Is it something that, I can't remember when we started on this journey together, 20 plus years ago. Did we talk about dialysis adequacy, what it is? So how did you come to your understanding of it? Is it something that, we talked about proactively, or is it something that you've sort of gathered on your own from your many years of experience as a patient?
It's something that I heard a lot of. And I remember asking you, as a matter of fact, what does that mean? Because I was oblivion and I didn't want to know anything about any of this because I didn't want to be on it in the first place. So that's how I became to get the knowledge of what that meant. I asked questions, and I always heard them saying it, and then once I asked you, then I kind of knew. Oh, okay, it's the clearance, the time on the machine, and the volume, how much they're taking off each time. And I just ran into a problem that you had to help me with because I thought I was gonna like literally not make it out of dialysis, where my weight had changed, and you did tell them you need to raise Miss Rhodes' weight, and they didn't put it in the system. So because they didn't put that new weight in the system, they were going by my last weight and they were taking entirely too much off. And so I went through that for several treatments because they wasn't taking my word for it as the patient because they figured they were doing their job, what they saw in the system. And I said, no, that's it. I'm calling Dr. Tucker. And once I did that, it stopped. I feel much better now. And my clearances are great. I feel good. And it's not just about the number, it's about how I feel when they take those liters off and how I feel when I leave there.
Right. So one of the things that I'm really hearing in what you're saying about dialysis adequacy is you're really also emphasizing the fluid removal part of the dialysis treatment. And I think for many of us as clinicians, again, we focus on the urea clearance, the KTRV, and we think less about volume removal. And I think from the patient perspective, how you feel is so directly tied to the amount of volume that is removed, whether it's too little or too much. And that really, really impacts how patients feel. And so I think the other important concept that I want our learners to come away with is that volume removal is just as important in terms of thinking about the adequacy of dialysis as is small solute clearance, the KTRV.
Could I add something to that,
Yes,
Dr.
ma'am.
Tucker? I feel like that is so important, volume removal, absolutely. It's not only overall removal, but how quickly you remove it. That can make a huge difference. I feel like I've learned, over time. So again, because I do it at home, I program my machine. I'm the one that's putting in all the numbers, and it really does make a difference. To do for me, this is my prescription, but doing a low and slow really does make a difference in trying to pull a lot of fluid very quickly, or even a lot of fluid in general. That would be number one. And then the second is, and again, this is my own personal prescription, my disclaimer, I am not a fan of a high flow rate. I definitely feel like if you're doing a flow rate of 400 plus, like it feels like you are running a marathon. And so I do frequent dialysis. So I do a slow flow rate and slow removal, and it really does make a difference on, kind of the quality of dialysis and how I feel after a treatment. I don't feel winded or like I can't do anything. I can just kind of get up and go. Usually, not totally, I'll be truthful, but understanding what that feels like is really important for the patient. So just something to think about of the volume, how quickly and how fast and overall.
So you raised two important concepts there. One of which is a great segue to the question that I'm going to ask Mr. Moore in a minute. But I just want to make a comment about something that you said about blood flow rates. So historically, in the United States, we have really tried to use high blood flow rates compared to the blood flow rates that are used in other parts of the world. So we will try for a blood flow rate of 400 with the dialysate flow rate of, say 1.5 to 2 times that blood flow rate. And the reason that we do that is that with relatively short times on dialysis, you can achieve a good urea clearance within a relatively short period of time. other parts of the world, however, patients tend to dialyze for longer periods of time with lower blood flows. And I think that's one of the reasons perhaps that our outcomes in the United States have not been as good as they have been in other parts of the world, because historically we try to get patients dialyzed in a relatively short period of time. And we do that with high blood flows, which I think may have some impact on how patients feel, but it also may have some impact on the longevity of the vascular access, which is something else that one has to think about. Now, we got to where we are in this country in terms of short dialysis times for a reason, and that was that we had limited capacity for dialysis, and we had a growing number of patients. But as our number of dialysis clinics has expanded from where we were in the 1970s and 1980s, now I think it's the time for us to rethink that and really think about, okay, do we need a blood flow of 400? Maybe we need a slightly longer time, which will allow us to get the volume off with less hypotensive events. But I think that from a patient perspective, more chair time is always less desirable. And so there's that balance, chair time and patient satisfaction versus what we think is good for the patient over the long term. And I'll come back to that, over the long term, because I think that's really important. So I want to turn to Mr. Moore and ask him, from his perspective as a nurse, when you're talking to patients and you work primarily in the inpatient setting in the hospital about their time on dialysis, how do you approach it with them? What do you say, particularly if the patient is having a lot of hypotensive events, but is fluid overloaded and needs to get volume off? And patient says, I only dialyze 3 hours at my outpatient clinic. And the clinician may be trying to increase that time, but patients are resistant. How do you approach patients about that and trying to get them to understand that perhaps we can get more volume off if we increase their time on dialysis?
Yes, that is always a struggle, trying to extend somebody's time. But I try to explain to them that it's not only their prescription time isn't just the clearance of the waste products, but also the volume coming off in a shorter period of time. So I have to break it down into basic math as to what the volume is that's being removed per hour. And if by extending that time, we're able to reduce that rate. And I think both patients have explained that it washes a patient out taking off a large amount of volume per hour. That's I think the most taxing part of dialysis is washing a patient out, removing too much fluid too quickly.
I think that's really an important concept. And when I'm talking to patients, particularly in the hospital setting, is I use the pouring water out of a cup concept. So I've got my coffee mug here, and what I'll do is I'll say I can pour the water very fast, or I can pour it very slowly from one cup into another. And if I remove a lot of fluid in a short period of time, that's pouring the water very quickly, and that leads to more symptoms, more cramping, more hypotension, and probably more post-dialysis fatigue. So that's, I think, a really, really important concept, an issue that I think we all struggle with in terms of how do we explain it to patients in a way that makes them more willing to increase their time on dialysis as needed. So I want to turn back to home for a minute, since both of you have done home dialysis, and I'll start with you, Ms. Rhodes. So back when you were on PD, how did you and I think about adequacy of dialysis when you were on PD? Do you remember? It's been a while.
Oh, I remember, because if I could go back, I would do it all over again. minus the encapsulating peritonitis and sclerosis. But it was basically how I would tell you how I felt in between appointments. If I needed a 4.25, if I felt heavy, I would use the 4.25s. If I felt like I was too not getting enough, then I knew I had to use the yellow. So it didn't happen overnight, but I learned how it made me feel. If I felt when I'm holding on all that fluid, if I couldn't hardly breathe, even if my 4 hours wasn't up, I went and I did an exchange. So depending on how I felt, I knew which which color to use and which percentage of dialysate to use. And it was something that I had to learn.
Great. So I think that perspective is really important. So for our learners, you're going to hear from this afternoon from Dr. Joanne Bargman from Toronto, who's one of the world's leading peritoneal dialysis experts. She's someone who taught me so much about peritoneal dialysis. And one of the things I learned from Dr. Bargman is that the concept of KT/V and PD is really not that helpful. In other parts of the world, in Canada, they don't even measure KT/V in peritoneal dialysis because KT/V is much more predictive of outcomes in hemo than it is in PD. And so I think it's really important for us to think about how does the patient feel? And to me, that is much more important when I'm dealing with my peritoneal dialysis patients in terms of thinking about their adequacy than their KT/V. So I have a patient right now whose KT/V is just under the target, but he feels great. And he's always nervous when he comes to clinic that I'm going to say, oh, we have to do more. And I said, no, I don't think so. You're doing well. His albumin is great. He feels great. He's working full time. He's traveling. He's doing all the things that he wants to do. So I think he's doing quite well. Ms. Evans, from your perspective as a home patient, what is different for you doing home therapies in terms of the things how you tolerate dialysis, and perhaps how much volume you can take in or how much potassium you can have since you're dialyzing more frequently?
Sure. So I don't really think about measuring anything in terms of what I'm eating or drinking. I do dialysis 5-6 days a week, more frequently. I do it on my own schedule. So I usually do it at night because I work a full-time job. And so that's what works for me, but I can change it around if I need to. And so I don't really worry, in terms of like my labs, all of that looks really, really good. Thank God, right? So that's how I think I've been able to be a long-term patient. I think there's something to be said about doing more frequent therapy, certainly long-term. My life is very, very different than when it was in center. I'll be very truthful. I didn't know anything about home when I first started in center. Nobody spoke to me about PD or HHD or anything. That's changed now. I think we do a lot more talking about home, which makes me very happy because I think the one thing that I'd want to tell the people on the call today is that dialysis is a journey, and we never get to tap out. Like you might be able to get a transplant, and then there are other things that you're worrying about and that you're doing, and it's not dialysis, but there's never a quote unquote cure. And so it is really important for people in this space to understand all the modalities and be very transparent with your patient and think about, what might have been good for me 20 years ago might not be good for me now. And I don't know what will be in the next, 20 years. And so it is a journey. And I would implore, physicians not to make the choice for the patient, but make the choice with the patient. I hear so many times, oh no, they're not going to be good for home because they don't come, or right. And so I know you didn't really ask me that, and I'm kind of going off a little, but I just think that it really is a journey, and it's important to have the patient be a part of it, because then they understand what foods to pick and how to think. I remember when I was in center, and if I had a good treatment, I'd think, what did I eat today so I can do the same thing the next time? And that really doesn't work, right? I would try to eat exactly the same thing. And there's so much more with body chemistry, what's going on, social, emotional, right? It's much more than just the dialysis treatment. There's a lot more to it. And so it's important to really understand the patient, their dynamics at home, their transportation needs, how do they eat, etc., to really think about them holistically. And I would also say, have them speak with a peer. Somebody that's done PD, somebody that's done home chemo, somebody that's done in center, and then they can walk through it at that point in their life. So, those are all pieces that I think are really important as you're decision making and speaking with your patient. I also, by the way, don't really look at KT over V because it doesn't measure correctly when you're a home patient. Right? My KT over V is usually pretty high, but there's no measurement really. It's only on a monthly, so it's like a variable, right? And so understanding kind of the trend, I think, is also important.
Thank you. And I really love that concept that you alluded to of peer education.
Yeah.
So Ms. Rhodes knows I have called on her so many times to talk to other patients who are scared about either modality, about peritoneal dialysis or hemodialysis. And because she has done both modalities and she's always willing, one of the reasons that she's here today is because she's a great educator and she's always willing to talk to patients. And so I think that peer education can be really, really helpful. The other thing that I think that is important that you emphasize is thinking about the patient holistically.
Yes.
What is it that's going on in the patient's life, and not just what's happening there in the clinic, and understanding, are we doing everything that we can to help the patient to live his or her life to the fullest extent possible? And to me, that is adequate dialysis. We can get that patient to be able to do the things that he or she wants to do. If it's working or going to school, raising a family, traveling, to me, those all fall into the arena of adequate dialysis. So, Mr. Moore, I want to ask you, since you've been at this a long time, how do you educate? Because being the charge nurse for a long time in the hospital, how do you help to educate new nurses about the concept of adequate dialysis? When someone's, you hire someone new and they're new to in-center dialysis or new to hospital-based dialysis, what's your approach in terms of educating them?
Most nurses already have a background in chronic dialysis, and adequacy is always just solute removal or removal of waste products. But again, it just goes a lot further when it comes to the volume removal. And when we tie it into adequacy, I kind of think it does it a disservice. They might be getting adequate dialysis from that solute removal aspect of dialysis, but I teach them when it comes to volume removal again. And when you are trying to remove 3 liters over 3 hours is a liter removed per hour. If we stretch that time to 4 hours, it's gentler on the patient. It's 0.75 liters per hour. So it's more the math of the volume removal being gentler on the patient. We're dialyzing the patients on the monitor, so you can see what happens on the monitor when you're trying to remove a liter per hour. The heart rate goes up, the people feel weak, fatigue, blood pressure drops.
Great.
I think we need to do a better job of incorporating volume removal with adequacy and not just solute removal.
I couldn't agree more. So we have a couple minutes left. There's one concept I want to discuss, and that's post-dialysis fatigue. A lot of patients, particularly our in-center patients, complain about, being fatigued post-dialysis. And one of the things that I often think about is maybe it's because the treatment time is too short. And if we, remove the solutes over a longer period of time, they'll actually have less fatigue. But some patients will tell me they feel more fatigued after a longer treatment time. So I'll start with you, Ms. Rhodes. Can you notice a difference in terms of post-dialysis fatigue with a short treatment versus a longer treatment?
Every day is different with me. I suffer from the hypotension, and some days I'm great, and some days I'm not. Some days they take not that much fluid off, and then I get home and I feel terrible. Then there's some days when they take, a substantial amount off that I could handle, which is 2.7 is my cutoff, and I feel good. So it's based on each treatment and how my body wants to react to that dialysis.
How about you, Ms. Evans? Any final thoughts on that concept?
Sorry, I put myself on mute. Okay. I agree a lot with what Daphne just said. I do think if you try to pull, more fluid in a short amount of time, you will feel it. Like that to me is kind of, yes, very black and white. I will go back to what I originally said, which is, and I struggle with this myself. I'm like, oh, do I do a longer treatment? Do I feel better? No, I don't think I feel better necessarily if I do a longer. Sometimes I actually feel better with a shorter treatment. I really believe in frequency. I do think that when you do more frequent therapy, you might be able to do a little shorter, although we know longer nocturnal and all that is going to be better, but you do have to balance it with your life and how you feel. I struggle a lot with sleeping, as I talked about before, and if I do dialysis, and sometimes I just and feel much better if I just don't do a treatment and I go to bed early and I have just a solid good night of sleep, and then maybe the next day I do a treatment. So you really, I think, and Daphne and I are kind of veteran dialysis patients, so we really know our body very, very well. And I think you start to learn that. I will say also that doing more frequent, I really barely take off much fluid, maybe a kilo if I have a big day, but I never have that 2-day skip ever. I'm doing dialysis basically almost every day or every other day, never have that 2-day skip. And I do think that makes a difference, but I don't know that there's a rhyme or reason, as I said, what did I eat that day that it was so great? I don't know. It's so much going on environmentally, chemistry, all of that. But I would say, low and slow and not taking off so much fluid. Now, patients never want to hear that they're going to be on dialysis longer. That's also really hard for us. So it's, again, a balancing act and trying to find what's right for that patient at that time.
Great. So thank you all for a great panel discussion. I think this is always so helpful for clinicians to hear directly from patients about what dialysis adequacy means. So I, again, appreciate your taking the time to help educate our learners. Thank you so much.
Thank you.
Thank you.
Thank you, Kevin. That was fantastic. Really wonderful to hear those patient perspectives and from nursing perspectives as well. Just really starts today on a fantastic note. And thank you so much for everyone who came to attend today and who came to participate in this. We really think it's incredibly valuable for us all as a community. All right, so we're going to move on to the second lecture. It's also Dr. Tucker, and he's going to speak about hemodiafiltration.